All right, looks like we're ready to go here. The ever-changing challenges of digital technology. So thank you for that. Just a quick shout out for any of the faculty who are AOA members online. There's a survey that was sent out to all AOA members. It's actually a study being done by Anna Miller from WashU, looking at exactly what Dr. Mormon just referenced was medical errors, and going to the lawsuit side of it and looking at feelings and perceived burnout associated with any time you've been involved with any kind of lawsuit, or which is sort of the epitome of patient complication when it adds to that legal side. So it's very interesting. But thanks for that talk. And we're going to shift gears here now and move on to a clinical topic. And we have Dr. Bulloch here to talk to us a little bit about idiopathic scoliosis and alternative treatment. Thanks.
Thank you, Dr. Pat. Good morning. Onto a lighter topic. I'm Landon Bulloch. Nice to meet you guys. For those I haven't met yet, PGY3, and I'm going to talk about vertebral body tethering. All right, so I have no financial disclosures to this talk. I only have to disclose that I did work closely with Dr. Pulaski, and he may or may not have disclosures. And we'll start quickly with a case. So this is a 13-year-old female. She presented with a 44-degree main thoracic curve from T6 to T12. She presented at a Rister stage 0 in Sanders classification 4 to 5. Looking here, so the hand radiograph here is what we use to measure bone age. With Sanders, it measures the closure of the epiphysis going from the phalanges down to the distal radius and ulna. I'll show a little bit more of that as we go on. And then on the right, the more classic is how we use Rister. So looking at the iliac crux hypothesis, and that helps us measure skeletal maturity. So just quickly in your heads on what we think our options are for this patient. So very briefly, this is the most prevalent spine deformity we see, the idiopathic scoliosis. It accounts for 80% of all the pediatric scoliosis types, and it's 1 to 3% of all children from the ages 10 to 16. And it's highly prevalent in females over males. And this here is the illustration for you guys, the Rister and the Sanders classifications. Important things to note for this is that curves that are presented at 25 degrees and their patients are skeletally immature, they have a significant risk of progression as they continue to develop. Curves that are greater than 45 degrees are going to continue to develop potentially after they finish skeletal maturity. And then just overall, 10 to 15% of all of these curves are going to progress when the kids present between the ages of 10 and 16. So current treatment options right now, some basics, curves less than 25 degrees, observation and physical therapy are accepted. Curves 20 to 40 degrees generally are recommended for TLSO bracing. Goals for bracing in this category are to prevent spinal curvature worsening and essentially get the kids to skeletal maturity so then they can potentially undergo fusion at that time. And then lastly, 45 to 50 degrees and up. So these are most likely going to be recommended for surgical intervention. Briefly here to talk about some bracing is this is a study by Carol et al. In 2016. So she took 168 kids that were prescribed braceware. Inclusion criteria for these were Rister stages 0 to 2 and 25 to 45 degree flexible curves. Overall, her study just showed that if the kids present with at least a 25 degree curve and they're still Rister stage 0, they have a huge chance of progressing to surgical need by the time they are fully developed. So 44% here. If they present a little bit later, so even just Rister stage 1, the risk dramatically decreases, and then it's almost unheard of if they present at stage 2. So overall, just the point of her study was regardless of bracing, if they present at that Rister stage 0, you are likely going to need surgical intervention in their future. And very quickly, a point about bracing that I don't know if anyone notices or pays attention to, but coming from what I used to be a teenage girl, it was hard enough. I can't imagine being a teenage girl in a back brace. Something we really should consider as if we are prescribing these for our patients. Overall, like what does this do to their mental health? Is it worth it? I mean, there are a lot of studies out there on this actually. This one looks at the effects it also has on parents. So parents are experiencing extreme emotional stress, just worrying about their kids and wearing the braces, and what does that mean? And how do they feel about themselves? So it's multifaceted. It's way beyond just the spinal curvature that we should be concerned about. And very briefly, I'm just going to highlight some fusion things, the things we already know, but this is our tried and true method. It provides a predictable correction. Been doing it for a long time. There's long-term data on this, but it is not without risks. So the pseudoarthrosis, adjacent segment, and loss of mobility, these are important things that we can't forget when we do these procedures. And I know a lot of times in the pediatric world, when we are doing the initial scoliosis, we don't follow them through adulthood, but this is something that the adult spine people are very much aware of. So I think collectively, you look at side effects from both bracing and from fusion and kind of the suboptimal aspects of that. I think it leaves the door open for innovation, and definitely a new solution would be welcomed in the world of idiopathic scoliosis. So that's kind of where we come into this vertebral body tethering process. So for those of you who haven't seen it or don't know about it, it is the endoscopic placement of screws on the convex aspect of these curves. So you enter in the thoracic cavity. You normally have a general surgeon or a cardiothoracic surgeon assist, so you can deflate the lung and safely enter the thoracic cavity. And that essentially places this tethering device, so screws with a more or less a rope, and you place compression on that convex side, and that allows growth on the contralateral side. So how does that work? Peter-Vogtman law, so compression on the physis will slow growth, whereas tension on the contralateral side will increase growth. And this is the same principle that we see when we are doing hemiepiphysodesis on extremities. So this is a well-known phenomenon that we already implement throughout our practice. So some goals of tethering. Overall, the primary correction is going to be in the coronal plane. In contrast to bracing, tethering is focused on correcting or at least significantly decreasing deformity. It's not just trying to stave off a future procedure. And big thing for this is preserving mobility and flexibility. That's a huge plus over traditional fusion. And it provides a minimally invasive alternative. So you saw the huge scar we had on that patient on the last slide. This will provide a much smaller procedure and less risk inherently come along with that. Important benefits over fusion. So POSNA and Scoliosis Research Society have released a statement as of April of last year. They indicate their support of vertebral body tethering, and they are urging for payer coverage of this procedure. Collectively, they have made these projections on their website. So they do believe that there's enough to suggest there's decreased length of stay, decreased blood loss, decreased narcotics use, overall decreased operative time compared to fusion procedures. And also the idea of preserving mobility shows this increased functional promise that we need to continue to foster and continue to look into. So choosing the right patient, this is going to be the most important part when we're discussing these procedures. Peter Newton has been a leader in this field. He's published several articles that I'm going to highlight as we go through, but he has kind of helped narrow down what is the ideal patient for this. So overall, these kids are between the ages for females 11 and 14, and for boys 13 to 16. They fit these classifications that we looked at on radiographs earlier. They have flexible curves that you've seen on radiographs, and they do not have a confounding kyphosis. As we stated before, in primary corrections in the coronal plane, we need to not have a confounding sagittal deformity as well. So FDA approved indications for this. So the tether right now is the only one by Zimmer that is released. It was approved by the FDA under a humanitarian device exemption in 2019. It has very strict indications. It states, major Cobb angle of less 30 to 65 degrees. They have to be structurally adequate to obtain screw fixation, which is questionable, but you have to be able to document that if you're the provider trying to get insurance to cover this. And they should have to have failed bracing or be intolerant to bracing. So again, you have to be able to prove to the companies that they do need this to be covered, that they are the appropriate candidate. And overall, I won't go into all these, but again, they're just very strict. So you've got to look into this if you're the provider looking to get tethering approved for your patient. Any of these listed here are going to make them disqualified. So does it work? The first study that ever showed the efficacy of vertebral body tethering was published in 2010 by Doctors Crawford and Lenke. This here is a data from that procedure. It was a case report from an 8-year-old male. Overall, his preoperative curve was 40 degrees, and by his 2-year follow-up, it was down to 6 degrees. These are from the original paper. You can see, even without measuring, you can tell the huge difference that the procedure made for this patient. results here. These were published in the Pediatric Journal of Orthopedics 2020. This was 21 patients that were followed in their first year of post-op. They had an average 48 degrees prior to their procedure, and their average last follow-up within a year was down to 10 degrees. So I think in short, we can all collectively agree that, yeah, this procedure does work. If that's the truth, then why don't we use it all the time? Right now, the biggest issue out there is complications. There's a high complication rate, most seen in the form of either a broken tether, an overcorrected curve, or some pulmonary issues. A lot of literature out there on the complications. This was published out of the Shriners Hospital in Philadelphia. They followed their first 11 patients they did this procedure on. They had 0 neurologic complications, which I think is impressive. However, had one kid with persistent atelectasis. And they did state in their conclusions was the power of overcorrection that can be seen in these devices is huge. They were cautioning surgeons going forward to be wary of over-tightening in that initial procedure. This is another paper published by Newton and JBJS. He followed 17 of his own patients, and he defined his success as having a residual curve at the 2 to 4 year mark of less than 35 degrees, and that they did not subsequently undergo a fusion. So he only had a 59% success rate, which in the overall is not ideal. 17 total patients, 7 of them ended up going revision. So again, continue to follow Newton. He is keeping us up to date. 2020, he followed 5 of his patients, and overall within 4 years, they had 20 events that he would call adverse events. Only 4 were called major events, but these included things like pneumonia, curve progression that required fusion, and overcorrection of their original curve past 10 degrees. So this brings us back to our case. I met our patient here in the office. She was 6 weeks out from her tethering procedure, and her radiographs already show a decrease of her main thoracic curve from 44 degrees preoperatively down to 33. She was happy. She had 0 pain. She had full flexion extension of her spine. She was, touching her toes, no pain, no stiffness documented then. And this is her at her most recent follow-up. So she's approximately 6 months out. Her Cobb angle here is still measuring a stable 33 degrees. She is now continuing to grow as well. So you have to zoom in here, but she's now classified as a risk for stage 1. We have maintained her decrease in curvature. So she's showing stable results, and she is actually back to ice skating. She's happy. She has no stiffness overall. So I think that she is a huge win, and shows us that in the right patient, in the healthy patient with the appropriate curve, that they are able to be significantly corrected and move forward with their lives and preserve their mobility. So overall, with these patients, I think we can all agree that vertebral body tethering is a powerful growth modulator. It is appropriate in the right patient, and it can produce significant results. We've documented that we can prevent fusions. However, it does not come without risk. So it's a great alternative, as we already said, to bracing, but it does not completely replace it, and it has significant complications. And we need to continue to do research in this and find the appropriate technique, so we do not place our patients at risk when we do offer them this procedure. A huge thank you to Dr. Pulaski and the FEEDS team and Dr. Spector, as always. And I'll now take questions.
Great, Landon. Question, I think that we had the orthopedic literature is replete with studies that have their final conclusion that blank is an appropriate procedure in the properly selected patient. This seems like it fits into that category pretty well. So what is your ideal patient after doing the study? And I think we talked about overcorrection as being one of the biggest issues. At 6 months, that person looks great, but they're risk 1. Are they going to be at high risk of overcorrection? Have people come up with strategies to, go in and cut the cords, if you will, to try and slow that process?
Yeah. So I think trying to follow the criteria that was published about really carefully looking at their staging. So you want them to have growth potential left. So risk 0 is ideal, but you have to just be particular. It's a healthy patient that will grow, and you've got to monitor them closely. to be able to document that they don't overcorrect. There are some documented cases where they do go in and snip the cord. That's kind of included in that revision procedure category. I think they further went into the standards because that's a little more detailed as far as picking the patients versus only 4 stages for RISR. But however, that's part of the question now is how do we more closely assess bone age? Like, we're getting close, we're starting to find them, we're doing the best we can, but clearly it's not perfect, and you have to really monitor these patients to make sure you don't overshoot it. And then that is where we're going to have to keep researching and perfecting that technique.
Hey, Landon, Mike Pulaski, longtime listener, first time caller. Doing these procedures, answering Dr. Pat's question, in that RISR 0 could be anywhere from the age of 2 to the age of 14, or 0 to 14 in kids, so finding that right RISR 0 is tough. It's where the Sanders comes in. And then finding that ideal patient that fits those FDA criteria, i.e. has some growth, not too much growth left, this 30 to 65 degree curve. It's flexible, not a lot of rotation. So it really narrows the window down on these kids, but it's intentional, and that's intentional by Zimmer and FDA to get the best outcomes, especially new on with this technique. I mean, it's not a new technique. There's been people stapling for 30 years, but just with the tether system, to get it right, in these kids. And it is a great segue or something different between just bracing or just fusion. They're almost kind of 2 extremes of the spectrum. So it is a nice something in the middle to offer them. But you're right, there is a very small subset of patients that really are ideal candidates for this. But there are some docs that have been doing this a lot longer than I that have ventured well out of those realms and do venture out of those realms. And we're lucky for them that they're pushing the envelope to see how these kids do. But that's the minority. For now, kind of sticking to that very small window. Once we learn more about this, the long-term effects, I think will be key. And then sometimes that's tough because a lot of patients will come in wanting this, reading this online. Hey, it's maintain your flexibility. It's minimally invasive. Done through a scope, but they're just not candidates. And knowing, for their benefit and explaining why and these rationalizations, those complications is important too, and not just jumping on everything with a curve.
I think I am incredibly biased with this procedure. So Dr. Newton's complications, I did 5 of those with him, like the complications and follow-up. So the publication he had in 2018 with his 7 patients with complications, going back in, miserable on these patients. And 3 of them we had to convert to an open thoracotomy because the pleural was so scarred down we couldn't even get to the tether. And the kids struggled post-op after those complications too. I think this is an amazing procedure and it works very well. You can see the correction that you can get, just like you do on knee plates around the knee. Similar concept as you described. And however, the complication rate and reoperation rate is so high. And I think part of that is a little bit of what Mike talked about is we're starting to learn more, but the science isn't there to tell us that key patient or those really narrow indications for this procedure. Dr. Newton had another publication kind of comparing 2-year outcomes of tethering versus a thoracic spinal fusion. Spinal fusions are not perfect either by any means, but that reoperation rate is so much higher in the tether group. You have to weigh those risks and benefits. And the other part that I struggle with, the science isn't there, is the 42-year-old that there are many people across the country that are doing tetherings on. I have a number of kids, and so does Mike and Brian, that we have put in braces. They're on that upper end, and they have never needed a surgery. And so a lot of that is the science of growth that we don't understand yet. I mean, this has been studied for years and years. RISR, I think we know now, RISR is not a good indication for growth. Sanders is better, but we're going to have something even better than that to be able to truly determine the right indication for this procedure. It works magically. but it's just fraught with a lot of complications
Like,
I agree, talk. I thought that was very interesting. This might be a question for Dr. Scannell or Dr. I wonder if you kind of look at doing things like non-segmental and not putting screws at every hole, maybe that section, this scarring or
So you're doing them endoscopically, you probably need it. I would be concerned about one of the complications. I think the more segments that you're skipping, the higher likelihood you could create more stress. And that would result in breaking those bones, which is already a real complication. I don't know that it makes it less invasive, less minimally invasive. I mean, it is. You're just using some portal sites, and it can be done quite. I don't know that there's much indication. It clearly works better than a lot of the old staples that were used. We have a lot similar to using staples around the knee. You have back out issues, dislodgement, which is a bigger deal in the chest out. Dr. Pulaski, I heard the words in the comments.
Yes. Still listening. Great talk. Great show. I think complications definitely being reported, and it's important to report these, that they, as this is a new procedure. So you're not biased. Don't say, yeah, exactly, this is great, everybody should have this. So I think there's still gonna be a lot of complications, and a broken tether is considered a complication. But if you can get these kids to skeletal maturity, even if they break their tether, but still keep their curves, 30, 35, even with a broken tether, it's listed as a complication, but you're still achieving your result of not fusing the spine and keeping the curve stable. Luckily, in my short career doing these, I haven't had a complication yet, but I'm sure it'll come. And there are those lung associated, pleural associated complications that I'm not looking forward to. This procedure I do with an access surgeon, a general surgeon, and done all of them with the same one, and plan to keep doing it with him to have that relationship of knowing what to do when the crap hits the fan, because eventually it will. But that's true for all procedures, and I'm just holding my breath to that first one. I think there's still a lot of good that can come of it. There's still a lot that we're learning, and as we narrow those indications, get better with the technique, get better with the implants that are currently going through revision. And I don't have any financial disclosures, although I wish I did. I think we're gonna find a spot where you'll have an ideal patient with acceptable complications. And I think the more studies that are coming out, right, we don't have a whole lot of long-term study like Dr. Snell was alluding to. Long-term studies for complications and revision, but I think historically this should be promising if you kind of compare it to the stapling, but kind of not. The reason this works better than stapling is because it shares the load over the entire construct instead of at each individual level, for those that are wondering. But on that note, I'll turn it back over to Landon.
Thank you, Dr. Pulaski. All right, Sam.
all right. Thanks for the good talk. Dr. Pat said one question. I'll try to sneak in a quick one. The first is sort of a follow-up to Dr. Snell's point about revision surgery being critical. I've never seen one of these. How complicated would it be to go in and just snip the tether if you're at risk of overcorrection? Why would that not be easy fix? That might be a question to the second good question is, I know from my time on each time that insurance approval, even with the community suspension, is extremely difficult here. Do you foresee in the coming years that we'll actually be able to get patients to
Yeah, so I'll defer to you guys as far as actually the sniffing of the tether, because again, it's not approved at Atrium yet. So they've been done at Novant. So I haven't seen them in person. We're working on it. I talked to Pulaski about that. They're getting it done here. I'm not sure when, but it's coming to Atrium. But Dr. Scannell, if you want to answer that.
You can absolutely cut the tether. It's just how do you get there? In some cases that I've seen, and I'm not doing these yet. Namely, one, I think the way that Dr. Plosky has approached it is the right way. He has a very narrow indication for it as well, which is good. I have had patients of mine that I've sent to him to talk to them about it. The issue is, can you get in endoscopically when you have some tune or condom, which is a big deal to cut the tether. So I've been involved with cases on both of those. So can you? Yes, absolutely. We did that on a couple of them. And I think a lot of that was the young, slightly immature kids that were probably overcorrected on the first surgery. That's the other piece of the science that we know nothing about is how much do you tension in between each vertebral body? How much correction do you go for based on their age, based on their growth remaining? You just don't have that data yet. A lot of it from a lot of the surgeons that do it, as is many of the things that we do, is well, it's just what felt. It's just that's a tough thing. Can you go in and cut it? Yeah, absolutely.
Really elementary question, but how do you put in a screw?
Pulaski.
You have your camera and
What was the question, Lynn?
Eric wants to know more technically, how do you actually place this tethering device to the endoscope?
Well, if I told you, then everybody would do it, and then I wouldn't see any patients. So
For a small price, I'll tell you.
no, Raspberry. Yeah, there's 3 anterior portals on the anterior axillary line for the camera, and then usually 3 larger 15-millimeter portals on the posterior axillary line for actual implantation of the screws. They're done through a cannula and a cannulated device system to get the screw in. The screw is not cannulated, and hopefully it's going through pricing negotiations right now. As with everything, this is a niche spinal product, which makes it take longer to get approved. And it's been approved for the IRB. The FDA says it has to be IRB. It's not an experimental device, but still has to have IRB approval because they're following data collection. It's been through that at Atrium. Right now it's in Dr. Kim's court for pricing because the price of this costs about the same as the implants for a fusion. So somewhere around 40 grand for 7-8 screws and a rope, but it's about the same price as if you would for 18 screws and 2 rods. But still, it's pretty expensive for a rope. So they're working out pricing negotiations. Hopefully, they come to a happy conclusion, so we can start getting these on the books to show you guys over at Atrium.
All right, thank you guys.
Thank you, Lynn.
Turn it back to Dr. Pat.
Thanks, everybody.